Hi, everyone. Welcome back to the 2020 Brain Health Online Summit. I am Amy Zellmer from Faces of TBI and the Brain Health Magazine. And I am a TBI survivor from a fall on the ice in February of 2014. And myself, along with Dr. Jeremy Schmo from the Functional Neurology Center, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those suffering from the lingering effects of a brain injury. So each weekday during the summit, you're going to hear from a presenter who will share with you either their real life experience living with a brain injury or working with patients who have brain injury. And today I am here with Dr. Cooper Dykstra, and Dr. Dykstra is a chiropractor at the Functional Neurology Center, and his main area of focus is on post-concussion syndrome, vertigo, dizziness, balance, and gait issues. He has a passion for helping people figure out the root cause of their problems and doing something about it. So welcome to the summit, Dr. Dykstra.
Thank you, Amy.
Today we're going to be talking about the cerebellum and rehab strategies. So I'm excited to hear more about this. So why don't you start out by sharing with us what is the cerebellum and what does it do?
Yeah, that sounds great. So I'm going to start off. I was an anatomy TA while I was in chiropractic college. So I'm going to start off by using a model here of the brain. Just kind of give people an idea of like where the cerebellum's at, and like kind of it's always important to know where the location of a part of the neurology is, because it usually makes sense of like the function of it then. Mm-hmm. So we have a brain here, and I'll kind of orient you here. Here's the front of it, and then if I turn it to the side, so this would be like in my head if I'm looking profile that way. Here's the front of it, and then you come to the side. Here's the parietal lobe, which is going to be a lot of your sensory. You have the motor cortex in the front, and then you have the temporal lobe on the side. But then when you get to the back of the skull by the occipital lobe, you'll see these two lobes at the bottom here. And these two spots, these are your two lobes of the cerebellum, which play a very important role. They're in a very protected area of the skull in the back as well, which I don't think that's by chance because it's so important for the brain. Mm-hmm. If you look from the front here, you have the brain stem coming out the bottom here, which turns into the spinal cord, going into the spine and into the limbs. And you can see how the cerebellum is strategically placed like right behind it because it's so tightly integrated with the brain stem. All the important reflexes that run through the brain stem have to be regulated and coordinated by the cerebellum. So a fun fact about the cerebellum is that there are more neurons in the cerebellum than there are throughout the rest of the brain itself. Which is saying something because it only takes up about 10% of the actual volume of the brain.
Yeah.
Yep. So here's a good analogy to kind of explain like the cerebellum. I have a couple analogies. So one being the tree. You have a tree, you have the roots. I explain the cerebellum as being the roots of the tree. It's like the roots of your neurology because you'll find it's at the base of everything. It weeds its way like into the cortex, it weeds its way like into the basal ganglia, into the brainstem, and coordinates all these activities like throughout the rest of the brain and works as really like a primary integrator. Another good example is like the conductor. You have all these different instruments, like all these different parts of the brain, but you need one guy that's like kind of coordinating all of it. And that's going to be your cerebellum as well. Works on coordinating all of these aspects of the brain.
So what would be, if you have damage to the cerebellum, what would some of the problems you might see manifest from that?
Yeah, so like some of the, like one of the main like symptoms that you would say in like textbook would be, balance dysfunction. Like your balance, you'll be all over the place, you'll be uncoordinated. You'll deal with like dizziness, nausea. A lot of times like we do see is like you'll get motion sickness, nausea on a boat, nausea in a car, just because the stimulation is just too much to deal with. And that kind of gets back, I'll break down a little bit more of like what the cerebellum and some of the circuitry of it. There's really like three main parts of the cerebellum. You have the cerebellum, the vestibulocerebellum, which is going to deal with like eye, head, and neck reflexes and keeping your eyes steady. You have the spinal cerebellum, which works with a lot of the reflexes throughout the spine and keeps your core steady. And then you have the cerebrocerebellum, which has the cerebrum, dealing with like the frontal cortex and the cognitive aspect. So when you're talking a coordinator of the brain, for a long time, the cerebellum was thought of as like just a coordinator of muscle. So like you'll have your simple tests, like if anyone's been to a neurology office, you see like the fast hands, you see like the pinky to nose testing, and like a classic sign will be like broken down movement like that, trying to hit your nose in coordination. Um, yeah.
And you had said, balance and gait and coordination. And so does that explain, when I would walk into the door frame thinking that I had room and smack right into the door frame?
Yeah, so that brings up a great point. Like with the specific circuitry with this, like with the vestibulocerebellum, that's more catered to like even like an optokinetic reflex, which has to do with like busy environments. So like while you're in a car, you're getting like all of this busy information, which can be really hard when you're dizzy, a lot of that stuff.
Mm-hmm.
And the cerebellum, what it does more specifically is it has these specific cells called Purkinje cells that work on gating all of this excitation coming into the brain. So like what I mean by gating is basically you have like, if you think of positive signs like as like sensory information, like excitation, all of that comes up through, let me get my model here again. All of that comes up through the spinal cord into the brainstem, and all of that sensory information has to go through the cerebellum. And the cerebellum pretty much does the big boy job and says like, hey, like we're going to work with this information, and this, and it has to inhibit all of that. So if your cerebellum's not working on one side, you're going to get too much of that information, causing like sensory overload. So you can get symptoms like anxiety, irritability, emotional reactivity, insomnia, like due to like racing thoughts, like if you're getting like too much of that excitation, light sensitivity, blood pressure changes, dealing with the reflexes in the brainstem, digestive issues, dealing with the vagus nerve, like not being able to control that as much, working with like nausea, which is kind of the connection between the motion sickness and the nausea feeling with that. Yeah.
So I remember, excuse me, when Dr. Schmo explained to me, so, I fell on the ice, I went straight back, I landed on the back of my head.
Okay.
And I had, really bad whiplash. I tore muscles, I dislocated my sternum. And he explained to me that even though like I kind of went back with whiplash, but he said it was like if you take a washcloth and wring it.
Yeah.
That was kind of the motion. And I assumed that would be the brainstem, cerebellum.
Yeah. So all of that together, that brings up a really good point. So there's three main, they're called peduncles in the brain. There's an inferior peduncle, cerebellar peduncle, a middle, and a superior. And all three of them are made for specific circuitry. So the bottom one's going to take in information from the spinal cord and from other sensory, like your muscle spindles. The middle one has communication with the brainstem at all times and is dealing with like reflexes with the vagus nerve, and other the vestibular nuclei and whatnot. And then the other one shifts information, the superior one shifts information like up into the cortex and works with more of a cognitive aspect of it. And you can really, like, we are talking about rehab too. You can specify some of your rehab. It's hard to like specify completely because like cerebellum is pretty much affected with everything, but you can specify your rehab based on those three bridges of the peduncles there. Okay. Anyway, little tangent there, but my point being is that the circuitry is really, it can be affected with concussion. And like Dr. Schmo was saying, like with the washcloth analogy, it can be a torsioned, and those bridges you can lose communication between the cerebellum and the brainstem, and then also lose communication like up to the brain, or lose the integrity of the communication, not quite as functional as it could be. So yeah. That's kind of what he was saying, like in your exam with him.
And I find it really fascinating, the more I learn about the brain, and just, like we know no two brain injuries are the same, right? No two recoveries will be the same, but like just how, I hit my head here, and
Yeah.
how, and plus whiplash on top of that, and how the neck, and seeing where the cerebellum is, I have to believe that that really ties in with the neck when
Yeah.
when you have a whiplash case, right? And how it's all so interconnected, and how you can have a neck injury and then, just have problems elsewhere. So,
Yeah, for sure. And there's like, and that brings up like another good point is, so there's a tract in the nervous system called the spinal cerebellar tract, which just a big long word to say spine to cerebellum. And what that does is it coordinates all the muscle spindles of the of the muscles themselves, which gives you feedback into your cerebellum and kind of keeps it alive. That's why movement is so important and exercise.
mhm.
Um, just in general. But talking about like a whiplash injury, if you lose that connection, like you traction some of the muscles and you lose some of that proprioceptive or like that feedback in the neck, you can mess with a lot of the reflexes, and you're going to need to do some rehab, some pretty specific rehab to reintegrate the cerebellum to talk to the eyes and coordinate the eyes and the head and the neck to all work together again, which you commonly see that with concussion and whiplash injuries.
So you use the word proprioception. Proprioception. Can you kind of explain what that means? That's a word we see going around a lot in articles, and I want to just take a moment and see if you can explain what that means. I know it, I think I know what it means, um, but maybe
We should
everyone
start
listening.
with you. What do you think it means?
I think it means broadly, um, like balance and knowing where you are in space.
Yeah, pretty accurate. I mean, proprioception is basically body feedback
Yeah.
going into the brain and telling you where you're at in space. So without like, if your arm was like completely numb, you wouldn't really know where it's at. And the most proprioception is going to be in the muscles, and all of that feedback goes into the cerebellum to keep it alive. So another good example and another like thing to understand with the cerebellum with concussion and with all these other like neurological concerns going on is gravity can be a really big issue, because what gravity does is it actually stimulates the muscle spindles and puts some activity into it and activates the cerebellum. But if your brain's not detecting gravity as well, and your body's not getting enough feedback like from gravity, and you're not making those connections, it can be really hard to start like coordinating your life, and then you feel unbalanced and you feel like, I mean, you can't really get away from gravity unless you go into space. So like, if you're not understanding gravity, you could deal with like some constant fatigue throughout the day just because you can't get rid of it, waking up really tired and everything like that.
That sounds familiar.
Yeah, right. Yeah, I was
Yeah,
gonna say every single brain injury out there.
yeah, yeah,
Yeah. Yep.
yeah. And I know, is that where like figure eights kind of come in?
Let's talk a little bit about the rehab. So a lot of the rehab, you're using all the sensory systems of the body in order to like coordinate them and work better together. So like a simple one to do for just muscle feedback and body feedback would just be a figure eight with the arm or the leg. You can do like a cross chord pattern with like the right arm and the left leg, depending on depending on each patient that comes in. You could have a
Which
right
is
cerebellum.
not as easy as it sounds
No,
at
yeah,
all.
yeah. It took me a little bit to get them to until I did like thousands of them with patients while I've been here. Um, but yeah, you can do complex movements. Some other ways to like get the muscles involved is you can do like weight holding. You can do like hold some kettlebells, and you can like do a lunge hold or a squat hold, and this is going to help like drive some of the muscle feedback going on those sides. Um, so I had talked about like three different parts of the cerebellum earlier. You have like the cerebrocerebellum, which is like the cognitive aspect. You have the spinal cerebellum, which is like the spinal part of it, and then you have the vestibular cerebellum. Um, some rehab specific for like the spinal cerebellum is going to be that works with like a lot of your spinal muscles. It's going to be like balance exercises, Bosu ball exercises. Like, have you had to stand on
Yeah.
the blue ball?
Yep.
Yeah, doing some exercises like that. Feet together, eyes open, eyes closed, going into a lunge, eyes open, eyes closed, like challenging the balance centers in different ways. Um, some specific rehab that we do for like the vestibulocerebellum, which works a lot more like with the integration of like the eye movements and everything, is going to be like gaze stability exercises. You know, the fancy 5-dot pattern that we use here. Then you look at the dots and we hold your head and you look right at the dots, doing gaze stability exercises. Another really good way to activate some of this like balance, some of the balance centers and the coordination of those optokinetic reflexes, like the reflexes of like the busy environment, the motion sickness type feelings that people get, is going to be the gyrostim that we have here. And you just can't hardly beat it with that, because you get through so many different axes of rotation and you have to coordinate. So like we're talking about the cerebellum and coordination, you have the targets in there and you have to coordinate, look at the target, hit the target, and create this whole coordinated movement while going through this axis of rotation and working with different graviceptive fields, so to say.
So
Go
I can share my story. So last week I came in, on my way into the clinic, I was getting in my car and smacked the side of my head on the car frame. And I sat there for a minute. I'm like, all right, I'm okay. But I could tell my eyes were off again.
Mm-hmm.
And so I came in and Dr. Cassie actually kind of checked me over and did the eye, I did all the eye, tilt my head, move my head. And then she had me doing the squats and lunges with weights, staring at a dot.
Mm-hmm.
And then the side to side, I don't know if there's a name.
Skater exercise.
Yep. And then then Dr. Schmo made me go in the gyrostim to get my eye, I don't know the word, to get my eyes back together again.
Yeah.
And, okay, I have to admit, I'm not a fan of the gyrostim.
Oh, come on.
But it freaking works. And so, because the reason I don't like it is because the exercise that works for me flips me backwards and upside down.
Yeah.
And Cassie put me, and it's literally 30 seconds maybe that I'm in there. And dang it if I didn't get out and I'm like, oh, hey, my eyes are fixed.
Yeah.
So not everybody goes upside down and backwards. It's a lot of what you're saying. You just kind of slowly go side by side.
Yeah, that's totally the thing with it too, is like you can, every patient that comes in is different. Some you're going to need to do that. Some you can't tolerate it because you have a whole, if people were watching the Brain Health Summit last year, like the whole dysautonomia piece that Dr. Brian talked about, sometimes you can't start with that. You got to kind of like work your way, steady the autonomics, and then work your way into doing more gyrostim stuff. But the gyrostim is really great because you're able to get more stimulation, because when it comes to the facts of it, real life isn't just one little room, like people want to get back to real life. Like when they come in here, and like, we want to get people back to real life so they can take on like all, traffic coming at them and stores and busy, everyone go watch the movies, like, so you can handle some of the more complex backgrounds that are in real life. And the gyrostim is a good way to help stimulate that under a controlled environment.
Yeah. And I know Cassie was telling me, she equated it with one patient. She's like, well, we could sit here and do 10 barbecue rolls, or I could put you in the gyrostim for a minute. Like you're just able to do so much more in the gyrostim than you can do just manually. Like, like with me, you couldn't lift me up and twirl me upside down, and to be, in all fairness, Jeremy did not have the gyrostim when I went through my intensive, so it's new to me.
Yeah, exactly. Yeah, some trust issues and stuff. Yeah.
So what are some ways when a new patient comes in and you're examining them, what are some things you're looking for specifically for the cerebellum?
Yeah, that's a great question. So some simple things, and this will kind of tie into like tests you can do at home. I'll kind of just tie that question like in with this. Some stuff you can do at home and some stuff that we check here is you can just simply bring your feet nice and close together and then close your eyes and see how your balance is with that. And oftentimes a tendency is to fall to the side of your dysfunction. So you can kind of counteract that with like some more tests. Another test that you'll see us do in clinic is you'll have your hands out in front of you, you'll close your eyes, and you need to coordinate and try and touch your pinky to your nose. Just a simple pinky to nose test with your eyes closed. And if you're like hitting yourself in the forehead, the mapping might be a little bit off on this side. You're not able to coordinate and plan a movement out as properly as someone with a functioning cerebellum would. And then it's kind of funny, like a lot of the testing that cops do for people who are drunk is going to be cerebellar testing because of the low oxygen just affects the cerebellum so much. It's so sensitive to that. So you can do a simple like heel to heel like walking test, as tandem line walking test. And then another one that we do in clinic is like a rapid alternating movement with the hands going kind of fast like that, like spirit hands or whatever they call it.
Jazz hands.
Yeah, jazz hands. There you go. And then more specifically, something that you'll have a harder time checking at home is a lot of the ocular tracking. We'll do a VNG test here and like graph your eyes out and really see like what's going on with the circuitry of your eye movements, because like all that it has to get coordinated by the cerebellum as well. And you can have testing in the dark, you can have like nystagmus patterns where you're like favoring one side of the cerebellum and the vestibular system too much or not enough, and different patterns like that will be able to check more in depth in clinic here.
And the VNG, that's where you wear the goggles and it records your eye movements?
Yeah, so it's like a test. I would say it takes like 10 to 15 minutes, just some simple tests. We try not to, for future patients, if they decide to like come and do this, it sounds scary looking at a dot and like doing a bunch of visual patterns, because that can be very like symptom provoking. But what you'll do is you put these goggles on and you follow a dot. It'll be steady at first, it'll go side to side and then go up and down, a couple of quick eye movements left and right, and we go at the pace of the patient with some of that.
And I mean, it has to be symptom provoking because you have to be able to assess,
like figure it out
where their deficits are coming from.
Yeah, exactly. Yeah, that's exactly right. And it's like looking at the eyes, it just tells you so much about the brain, because the brainstem, last time, I'll pull this out, I promise. Last time, the brainstem has all these reflexes and all the nuclei like housed for eye movements here. And all of that's coordinated by the cerebellum. So when you combine a VNG test with a bedside exam, a good bedside exam, checking the eye movements, you can actually confirm a lot of like what's going on with someone's brain health and what's going on with their integrity by checking some of the body-based stuff with some of the eye stuff. And you can really get an idea like where the deficit is in the cerebellum and the brainstem and everything.
Yeah. And the eye tracking and eye testing, the eye movements, that's something that's been around for ages, right? Yeah. And the whole bedside exam and checking the eyes and the eye tracking has kind of gone to the wayside in traditional medicine. And instead they put you in an MRI and it comes back clear, right? Which is good. It means you don't have a brain bleed or a lesion.
I remind people of that.
But just because your MRI says nothing's wrong doesn't mean nothing's wrong.
Exactly.
We've covered the eye stuff a lot in past summits, but and this year's summit, Jason Whitaker talks a lot about the eyes and eye tracking, but it really is a key component to most people's symptoms. Mm-hmm. And for me, I kept telling, so going back to your cerebellum testing, I remember when I went to the neurologist, first time I've done this test, she had me sit on her table, close my eyes, and touch my finger to my nose. And I remember going,
oh man, yeah.
And I was like, holy crap, like what just happened? Like I wasn't expecting that.
Yeah.
Like I had absolutely no idea where my nose was. Mm-hmm. And then the heel to toe, I couldn't do it. I just like fell right over.
Yeah.
And then standing up with my eyes closed, I think I fell backwards, if I remember right, and she had to catch me. But yet in my notes, I passed all my tests. So, I think that's what's so challenging. And I'm sure some people watching can relate to that.
Yeah.
And, when I first came to the Functional Neurology Center, and the first thing he did was he told me there was something wrong with my eyes. And that's what I had been telling the neurologist. I'm like, I think something's wrong with my eyes. That's why I'm dizzy. And she told me I just had positional vertigo. So I think a lot of people watching have also been told that.
Yeah.
So I think the eye stuff is not to be minimized,
Yeah.
and how much that affects our function.
Yeah. Yeah, it plays a large role, and it's a complex system, and it takes a really fine eye to like check some of these reflexes and see the coordination of all the bedside testing and all the V&G testing. Um, yeah, it's really important.
So what are some, I think we kind of talked about it a little bit, but so what are some of the things you're going to have a patient doing, um,
Yeah,
to
for
help
real.
them rehab? And, and again, you talked about people watching might be kind of nervous, like they don't want to flare it all up.
Yeah.
Um, but you do kind of have to push people to their limit to get that neuroplasticity.
Yeah, you do. Yeah. Yeah, and it's working that fine line between like pushing patients too much to fatigue, but also like gaining some performance out of it too, which is like all the doctors here are very, very good at that, at playing that fine line and making sure you're still gaining performance rather than just like coddling the person the whole time. Like, well, they're here because like people are here to get performance and like get back at real life.
Right.
But some of the rehab here, it looks like, at the beginning of the week, depending on the patient, like it might start out with like passive figure eights, like me, like just moving someone's arm, doing passive movements like that. And eventually working into like more balance exercises, doing like cross crawl, like gait pattern, like coordinated gait exercises, like marching in place, opposite arm, opposite leg, going forward and back, doing more of the translational type stuff. Um, and then also like the D2 board, like the red light board. And we also have a fit light, which is a similar idea. A light will turn on and then you have to like look at it and then you have to hit the target, which is going to help with your targeting of the eyes and getting your eyes to line up with that, as well as like doing a coordinated movement to hit it. So you help like remap that environment as well in front of you. So doing exercises like that. Um, Thinking, so some other ways is like doing the figure eights. Like I'm just thinking of like more progressions. um, a progression would be dual tasking
Mm,
after a while,
yep.
because that's going to get more of like the cognitive aspect of the cerebellum that we talked about earlier. Is you can do figure eights, maybe more complex figure eights as well, while doing every other month, backwards from 100 by sevens, doing more cognitive stuff to like, because you got to get the cortex involved with a lot of this
Mhm.
too in order to help with regulate some of that system.
And that's kind of real life too, right? Like we're always doing
Yeah.
2-3 things at once.
Yeah,
Yeah.
100%. Yeah, so you gotta get the dual tasking system going too with all of this. And it is more metabolically taxing, but like that's what's going to get you better for the real world, like you were saying.
Yeah.
Um, yeah, and then like I had talked about earlier, a lot of like different head and eye exercises, looking at the dots, maybe like looking at a target here and then quickly looking at a target over there, doing more like saccadic exercises, like quick eye movement exercises, and things like that.
Yeah. I remember, in the beginning, the simplest things were so hard,
Yeah.
like marching in place with the alternate hand and leg. I just remember being like, what is wrong with me? Like you don't realize all your deficits until you're faced with them. But I felt like they came back rather quickly, like I was able to
Yeah.
overcome those things.
The
And
neuroplasticity.
yeah, right? It's
Yeah.
just it's retraining your brain what it's supposed to do. And you guys also send everyone home,
Home exercises.
yeah, with home exercises. And I know that's where I saw gains immediately in my intensive, but then probably like 10 months down the road is where I really felt a lot of gains.
Yeah. Yeah. And like once you establish, like I like to think about it like with the cerebellum and some of the rehab strategies here, like once you reestablish those connections and kind of like recalibrate it, so to say, like while you're here, then those exercises are just meant for you to just like polish up your recalibration, like the cerebellar exercises when you go home. Um, and then that's what helps you. You go out and you feel a little overstimulated while you do your exercises like a
Yeah.
little bit later, and or you do them before the day and after the day, because a healthy brain does both. It goes through your fight or flight and it goes through your resting phase. So a healthy brain is going to help you with both of that. And cerebellar exercises can be a good way to help mediate a lot of that.
Yeah, I remember like the multitasking type things, like walking while tossing a ball from one hand to the other
Yeah.
while doing math problems.
Yeah.
Like, or Jeremy would throw a tennis ball and I had to catch it with the same side that he threw it from. And
Oh,
then
yeah.
we'd alternate to crossing it. And I had to do like math or alphabetical or whatever. I remember those were the things that I really felt helped me with overstimulation in a crowded and loud environment, like going
Very
out
cool.
to eat or to a mall. I think those were really the keys for me to because I think that was the longest lingering thing for me was the overstimulation,
Overstimulation. Yeah.
especially like if it's the end of the day and then now we're going out to eat and it would just be like,
Yeah.
just like shut down.
Yeah, and that kind of makes sense, like full circle. Like we were talking about the cerebellum as like the gating process, how it helps like cool down like all this sensory overload. So adding more cerebellar exercises to your daily routine is going to help with some of that overstimulation because it helps modulate and coordinate all of that sensory information that's coming in, whether it be light, sound, movement, other types of movements in the background and stuff like that. That's going to help with that sensory overload.
Yeah.
Yeah.
So Cooper, anything that we didn't talk about with the cerebellum that you wanted to make sure we covered, or did we kind of cover it all?
I think we kind of got it. I think we got it all. Yeah, that was good. I mean, like, of course, like everyone should like try doing these tests at home on themselves. Like that's what I would say. Like try doing a balance test on yourself. Do a pinky to nose test. Go really fast back and forth, jazz hands, back
Because
and
what are
forth.
you looking for with this?
So yeah, so if you have one side that's fast, and if one side feels weird and it's like kind of going in and out, yeah, you'll know which one feels off. Like
And
usually
is
you
this
can
one
feel
of
it.
them too?
So that'll be more of like a frontal lobe test. So you can do that one too. Yeah. Um, I would start off doing some of that. And if some of that stuff feels off, or if your balance is like way off, like definitely give us a call and like let's just let's check it out. Let's get a more specific exam on you and get you in the V&G goggles, see what's going on with your eyes and get the cerebellum working because we know how much it can help with
Yeah.
balance and everything. Keep
And
it stable.
the thing is too, like every patient, every brain injury is different. And so every patient, every treatment plan is individualized.
Yep.
And, I can attest to that. I've seen you guys working with so many different people, and it's pretty cool how you guys can really pinpoint. And like, if you do a rehab exercise and it blows the person up, you're like, oh, maybe that was the wrong one. And then you
Yeah,
do the
exactly.
other one and that
Modify
calms
it.
it back down. And I know that was, with Jeremy, I just blew you up. Let's bring you
Yeah,
back down again.
exactly. Exactly.
But it is a little bit of trial and error too. And, but it's always fascinating to me how you guys are really able to pinpoint what it is
Yep.
that you need to do with each patient.
Always a different feel every week here, which I love about it. It's always something new. Nothing ever looks the same. It's special for everyone, unique for everyone.
Yeah,
Yep.
awesome. Well,
Yep.
thank you so much, Dr. Dykstra. This has been really great information, and I hope that people at home do some of those tests and are like, oh, okay, this is real. If you've been dismissed by your traditional doctors, you can do some of the, like, it still blows my mind that my neurologist wrote in my notes, like, I passed all those tests because
You're not going to get away with that.
clearly didn't.
Yeah.
So anyway, thank you,
I
Dr.
appreciate it.
Dykstra.
Thank you very much, Amy. Thanks,
And
everyone.
thank you everyone for watching. And don't forget, if you're not able to catch all of the live episodes, you could grab the recordings for just $29 with proceeds going to the Love Your Brain Foundation. And if you missed previous year's summits, you can also purchase all past years plus this year. So thank you again for watching, and I'll see you in the next episode.